So I have been given 40 minutes. This is going to be a case-based presentation. I have about 16 cases. So without much ado, let's start. And I have I had requested the organizers, which was duly complied that I need some few residents who can discuss the cases for me to make it more interesting and interactive. So there are no conflicts of any sort, and this presentation is based mainly on my experience with few references taken from the literature. All the cases are from routine clinical practice. So before we go through the possible pitfalls in thyroid cytology, let's see how do we classify thyroid cytology aspirates. So you all know this. Just for a revision, there are 6 categories from 1 to 6. 1 is unsatisfactory, 2 is benign, 3 is AUS, 4 is follicular neoplasm, 5 is suspicious for malignancy, and 6 is malignant. AUS, ATP of undetermined significance, is further subclassified into 6 subcategories. AUS-C, C is for cytological atypia. AUS-A, architectural atypia. So you have to call something as C when you're thinking of nuclear features which are suspicious for PTC, but they're not enough to be called category 5. AUS-A, when you have microfollicles, the new Bethesda, they also added 3D clusters and 3D fragments into this. AUS-A and C, when you have a combined features of cytological and architectural atypia. AUS-H, when you have a predominance of oncocytic atypia. AUS-L, lymphoid atypia, and NOS, when you cannot fit into any of these categories. So this is just an overview of what we have in Bethesda. So can we have our first resident volunteer, please? Anybody? Yeah. So don't worry. These are all diagnostic pitfalls. All of us are bound to make mistakes. We also made mistakes. That's why I brought these cases up. So case 1, 7-month-old male, a thyroid nodule aspirate, very cellular aspirate. You can see a lot of vascularized fragments with stroma. Again, the pap stain smear, lot of cellularity, no colloid in the background. A higher part showing nuclei are predominantly round in shape with rare nuclear grooves, no inclusions. There's an abrupt nuclear pleomorphism with sudden large nuclei, but chromatin is similar to the background nuclei. Over here you can see some vascularized fragments, no colloid in the background. This is the MGG stain smear. So what would you like to call it? Bethesda category. Category 3. Would you like to subtype it? So cytological atypia you call something when you're thinking of PTC. Are you thinking of PTC in this? There are no nuclear features of PTC. So it's better to call it AUS-NOS. Now, can you do something about this patient? Instead of giving it AUS, do you want to, it's a waste basket. AUS is a waste basket. Do you want to better categorize it? For doing that, what will you do? So we went back to the clinician. Okay, we asked them the ultrasound, we asked them the clinical, there was nothing on the form. So this was a patient who was hypothyroid, and on ultrasound it was a benign nodule. So now can you think of something? Young baby, few months old. So this was a case of Homogenetic Goiter. The large nuclei which you were seeing are called monster cells. Okay, there were no nuclear features of PTC. So it's a major pitfall. It can appear like AUS, it can appear like a predominantly microfollicular pattern. You can have nuclear atypia, but not the nuclear atypia of PTC. You can have those nuclear changes also, but they can be a varied presentation. So all hypercellular aspirates, with or without vascular fragments and nuclear pleomorphism, are not malignancies. So yeah. So you have to always go back. You may, in fact, the patient may be in euthyroid also. It may be an undiagnosed case, and it may present with a thyroid nodule. There may be some colloid. So it has different stages of aggressiveness depending upon the severity of the enzyme defect. Category 2. So now we did the clinical and the ultrasound findings, we can go back and call it category 2. Okay. So will you like to take another case? I have 16 cases. Case 2. So let's quickly go through it. We can have the questions at the end. So again, this was a hypocellular aspirate, no colloid in the background. We were seeing these vascularized 3D fragments. This is a papilloid fragment, but there is no vascular core, but it's a tight 3D papilloid fragment. Another fragment over here. So this is the high part of the first image. Nuclei are predominantly round, and there were no nuclear features of PTC, but yes, we did have these 3D vascular fragments. So what's the what's the Bethesda? So when do you call it category 4? So when your suspicion is follicular neoplasm, in this there are vascularized fragments, but there's no nucleotopia, there's no predominance of microfollicles, right? And it's you don't have colloid, so you cannot go category 2. So I would like to call it AUS, probably AUS-A, because 3D fragments have now been included into the Bethesda. But I feel AUS-A should be used when there's predominance of microfollicles, but we have to follow the guidelines. So I called it AUS-A without any nuclear atypia. Well, this turned out to be an adenomatous goiter. So you can see from where these papilloid fragments came. You can see something over here which looks similar to what we have. So there was a lot of hyperplasia of the follicular lining. Another area. So this is the papilloid fragment which I talked to you about, and this is pseudopapillary hyperplasia. So adenomatous goiter, all aspirates with papilloid fragments are not PTCs. Do look for nuclear features of PTC. There have been instances when the tight fragments in aspirates without the nuclear features have been just screened in low power and called PTC. So be careful. Case 3. Very cellular aspirate, again a thyroid nodule, no specific clinical history. Very cellular aspirate, no colloid. We have these focal areas of microfollicles, and there are these tight papilloid fragments. Another fragment with some nuclear atypia, although there, you can see some platelet clumps also. There is some nuclear enlargement, a partial groove. Somewhere there are longitudinal grooves throughout the axis of the long axis of the nucleus. One more focus showing some microfollicles filled with colloid, and again a tight fragment. Pap stains may have the same. You can see some RBC, so probably a vessel. I'm not sure because I don't see any endothelial cells, but again, tight 3-dimensional fragments.
Any other resident want to answer this? Yeah.
So all are not category 3 in my presentation. So are you seeing so many microfollicles? I don't totally disagree with you. There are 3D fragments, they are tight papilloid fragments. So there can be an inter-observer variability which is acceptable. It can be called either 4 or 5 depending upon the severity of the nuclear features. So hypercellularity is there in many of the categories. It's there even in 3. So in 3 subcategories, if you see hypercellularity but with patchy nuclear features, you can call it AUS. So hypercellularity is not the sole criterion. You have to look at other features also, but I agree with you. You can call it for, somebody may call it category 5, but there were no Samoma bodies, rare, doubtful inclusion was there. So category 4 versus 5. So well, this turned out to be an invasive follicular variant of papillary thyroid carcinoma. So there were no true papillae in this entire specimen. We had processed it in its entirety. And you can see the clearly overt nuclear features on histopathology. So all aspirates with papilloid fragments are not classical PTC. So all with papilloid are not PTC. All with papilloid are not classical PTC. So this was case 3. Case 4. Any of you can take up. So a very cellular aspirate, no colloid in the background. You are seeing these true papillae. You can see the vascular core, very beautiful tree-like arrangement. There was focal discohesion. Nuclei are a bit elongated. They look darker staining, but they don't have the nuclear features of PTC. We could definitely see a rare groove. I'm not able to locate it here, but there were rare grooves on hunting. And they had these nondescript, ill-defined cell margins.
So I would like to
Very good. So in which category, in which type of medullary do you see papillary fragments? Is there any variant? So there's no variant of MTC, but you can get various architectural patterns. So there's a pseudo papillary pattern, but in this you are having true papillae. So this was a problem for me. It didn't look like PTC to me. I was not sure what I'm dealing with. There were no inclusions. So we're calling it something category 6. You need to have intranuclear inclusion, Samoma bodies, 2 papillae. We did have one, but we didn't have the other 2. So I went back to the clinician. I got the ultrasound. TARADS was high. It was 5. So I ended up calling it category 6, but I totally agree with you. You can call it 5, suspicious for carcinoma. Not sure, PTC versus MTC. That's very well acceptable. So any guesses as to what it turned out to be? A rare case, but a diagnostic aspirate. It was a case of columnar subtype of papillary thyroid carcinoma. Okay, so this patient also had lymph node metastasis. That's why they could tell me that it is category TARADS 5. So aspirates with 2 papillae, but absent or subtle nuclear features. It may be one of the PTC subtypes. It may be an MTC with a pseudopapillary architecture. It may be follicular adenoma with papillary hyperplasia, which was discussed by Dr. Uma Nahar yesterday. It can be a case of papillary hyperplasia, and you have to rule out metastasis in this. So I'm not saying that this case you will consider all these differentials. No, I'm just giving you differentials when you see papillae or 2 papillae in an aspirate. In this case, you cannot have all these differentials. Coming to case number 5, just continue. So this particular aspirate, abundant colloid, you can see dispersed follicular cells in the background. Now, suddenly out of the blue, we had these particular clusters which had some amount of abundant cytoplasm. There was a nuclear enlargement. There was definite nuclear folding and membrane irregularity, but we didn't see any definite intranuclear inclusion. So abundant colloid with atypical cells showing some nuclear features of PTC, including nuclear score of 2, grooving and enlargement. Which type? Cytological atypia. So in a background of colloid, you're getting some atypical cells in a background of not only colloid, some benign follicular cells also, right? And not a very cellular aspirate. So you are correct. This was a case of adrenomatous goiter with palpation thyroiditis. You can see the granulomas, and interestingly, the granulomas were present on the anterior surface of the thyroid. That's how I sectioned it and realized they're all present on the anterior surface. So this was a case of palpation thyroiditis with adenomatous change. There was focal oncocytic metaplasia, and these cells looked exactly like what we had on the aspirate. So this was adenomatous. We now call it follicular nodular disease as per the new WHO with palpation thyroiditis and oncocytic metaplasia. I prefer to still use the term AG because that's what my clinicians are used to. So cytological atypia mimicking PTC can be seen in many non-PTC conditions. Adenomatous goiter, lymphocytic thyroiditis, hyperplastic nodule, hyalonizing trabecular tumor, oncocytic neoplasms, MTC. So oncocytic neoplasms particularly, they can even show you inclusions. So be careful when you call something category 5 or 6. Case number 6, a very hypocellular aspirate, no colloid in the background. We had some very few such fragments which were cellular. You can see nuclear features of PTC are there. There is nuclear enlargement, some chromatin clearing, occasional doubtful whether, I'm not sure whether it's artifactual or true, but intranuclear inclusion was there at the time of aspiration. So what would you like to call it? Category 5, but it's a hypocellular aspirate. So 5 and 6, you need to have at least moderately cellular to hypercellular aspirate. Will you like to revise your category? Very good. Considering the hypocellular aspirate, you'll call it category 3. Now, I didn't show you one feature which is very subtle in this. So can you see some lymphocytes over here? 1, 2, 3, 4, 5. Some centrocyte nuclei, some dark staining nuclei. So that was in retrospect. I cannot say that I saw it at the first time. This turned out to be Hashimoto thyroiditis on histopath examination. So again, cytological atypia mimicking PTC can be seen in many non-PTC conditions, which I've already enumerated and enlisted. So you should be especially careful when you're dealing with hypocellular aspirates. Again, go back to your clinician. Always get the thyroid function test at the time of assessing the aspirates, which it was discussed very beautifully today morning. So case number 7. Yeah. So this aspirate depends upon the type. I didn't call it Hashi. This aspirate depends upon the site of aspiration. That particular focus. That's what I'm saying. So I call it AUSC. I cannot call it thyroiditis. This is cytological pitfall. That's all. So case 7. Abundant colloid, a very cellular aspirate with lot of fragments, 3D fragments. Some of them are vascularized. And you can see what are these white zones? Scalloping and resorption vacuoles. So these were very prominent, again, abundant colloid. There was some macrofollicular architecture. Most of the nuclei were looking benign, round, focal microfollicular arrangement, very round nuclei. There were some who were within these fragments, and there were some which were showing nuclear grooves and some enlargement and overlapping. Another focus, another opened up macrofollicle. This is a high power view. You can see some nuclear grooves. I was not sure whether there's some distortion because of smearing, because at the periphery they were looking pretty round. Very good. What are the reasons? What about scalloping and colloid in the background? Will you still like to call it category 5? That goes more in, and the presence of macrofollicles. So that goes more in favor of an adenomatous benign nodule. We called it, I was thinking this is probably a hyperplastic nodule, so many macrofollicles, so much colloid, and probably the nuclear ATPI is reactive. And but I'm afraid you are right, I was wrong. So it turned out to be a case of, anybody tell me? It turned out to be a case of macrofollicular papillary thyroid carcinoma. So you can see this is a large macrofollicle. The macrofollicle is filled with colloid. You can see the same resorption vacuoles here and then intranuclear inclusion over here. So this, I'll come to the discussion later. So there was a lymph node metastasis also in this particular patient. Case number 8, would you like to continue? So this aspirate again had colloid in the background, and it was not very cellular. It was a hypocellular aspirate, mainly colloid, with this occasional fragment showing mainly round nuclei of the follicular cells. And again, you can see these fire flares in the background. There were no nuclear grooves. So what would you like to call it? This is category 2. I called it category 2. Pardon me, ma'am? Yeah, there are some lymphocytes in the background. Actually, they can be confused with follicular cell nuclei. So, well, this was not my focus. This also turned out to be macrofollicular PTC on HPE. So because I'll come to the discussion. Case 9. Again, abundant colloid, lot of cyst and hemosiderin-laden macrophages in the left-sided image, and opened up macrofollicle without any nuclear features of PTC. On GMSA, lot of colloid in the background, and similar fragments, but they tend to show some nuclear grooving, and I was not sure over here whether to consider the PAP stain as final, that was H3 actually, that was an outside slide, or whether to consider this ATPI as final. So what will you like to call it? I would say category 5. No, so this is not category 5. This will be AUSC, or you can even call it category 2. So depending upon how much ATPI you have. Again, this was a case of macrofollicular PTC on histopath examination. So this is a recent review of, not a review, this is an original case series of macrofollicular PTCs, and it was seen that as many as 60% of the cases were called Bethesda 2 on cytology, 30% category 4, and only 1 was called category 6. And interestingly, all of these, the macrofollicular PTC, even on ultrasound, usually has a lower thyroids. Why? Because you have large macrofollicles and you have abundant colloid. So it gives a spongiform look on ultrasound, and you get a low thyroid. So that can be a pitfall in itself. On aspirate, you will get a low cellularity, abundant colloid, macro or microfollicles without dissociated clusters. By definition, papillae are absent, and the nuclear features are also absent or focal. Especially on cytology, it's difficult to pick up. Another series of 4 cases in which 3 were called benign and 1 was called PTC. And This was by Bongiovanni et al. So he is a well-known person in thyroid cytology, and you can see. And on macroscopy, gross examination of these specimens also, they were all called colloid nodule. This is a review of 35 cases in which 29% were called benign on aspiration and 37% were called PTC. So again, the diagnosis has ranged from category 2 to 3 to 4 to category 6. So abundant colloid, fire flares, and macrofollicles are features of colloid nodule or adenomatous change, but they can be present in macrofollicular PTC. That's what we need to remember. But please don't take home this message and start calling everything as macrofollicular PTC. Nuclear features in macrofollicular PTC can be absent or focal. Just to keep all this in mind. When I came across these cases, I was taken aback. I thought, especially the first case. The first case had lymph node metastasis, and I was actually taken aback. And that's when I went back and saw the smears again. Subsequently, somehow 2 more cases came within the next few months. So that's how I started collecting them and actually noticing these cases. Case 10. A very cellular aspirate. You can see tight 3D fragments and some singly dispersed discohesive cell clusters in the background. On high power, they had the predominant microfollicular architecture. Easy case. 2. Microfollicles, category 4. Okay. This turned out to be an intrathyroidal parathyroid adenoma. The nuclei were GATA3 positive and TTF1 negative. So the take-home messages: all follicular pattern aspirates are not thyroid follicular cell in origin. Usually they are FN, but parathyroid neoplasm, follicular pattern MTC, NIFP, and FEPTC need to be kept into the differential diagnosis. You need to look for ancillary finding. You need to, for parathyroid, it's very difficult to diagnose, but if the history is of a nodule which is behind the thyroid, the nuclei are small, round, hyperchromatic, and there is scan cytoplasm, then you can think of. But I think it's quite difficult to diagnose something as parathyroid, and suddenly you have the history. Okay, so we have few cases of spindle cell lesions. So a very cellular aspirate composed predominantly of spindle cells. There were numerous vascularized fragments. There was focal query, as if they are forming a round shaped acinar structure around some central space. Category 6 query MTC I called it category 6, probably MTC. So this was actually a case of spindle epithelial thyroid tumor with thymus-like elements. So just to bring out what all differentials you need to, you can see on thyroid aspirate. So this was settled spindle epithelial thyroid tumor with thymus-like elements. On retrospect, when we re-evaluated the thyroid aspirate, we found that there were some of these bodies which had the similar material, myxoid or mucoid material in the center. Another case, so all these are similar. You'll end up calling all of these category 5 or 6. Another spindle cell lesion with the nuclei being blunt-ended. They have nondescript cytoplasm, no amyloid, no nuclear features which were like that of MTC. So at this, so again, you don't need to stand up. I think it will be category 6 or 5 depending upon the cellularity. This was 6, category 6. I call it MTC, but we did immunocytochemistry. It was negative. So we were not sure what we are dealing with. It was a young child. I remember the patient. And we told them to do serum calcitonin levels. They were also negative. So they went ahead with resection. It turned out to be a case of primary synovial sarcoma of the thyroid. This is translocation X18. Yeah. So another case. Okay. So in retrospect, when we again went back to the smears, there was focal acinar arrangement, and some of these cells looked a bit different. So they were a bit polygonal as compared to the elongated nuclei, which we saw in the most of the aspirate, but these were difficult to pick up on routine cytomorphology. Next case, case number 13. So this was a hypocellular, less cellularity aspirate. We didn't see any colloid. There was mainly hemorrhage with some of these fragments which were composed of these spindle-shaped cells with blunt to pointed end nuclei, and they were amended within this collagenous sclerotic matrix. So again, another focus. So again, this was one of the difficult aspirates we had. We called it a spindle cell lesion, probably benign because there was no atypia, and even normal thyroid parenchyma or thyroid cells were not seen. So no, there was no necrosis. So this turned out to be a case of fibromatosis of the thyroid gland. You can see the spindle cells which are infiltrating and destroyed the thyroid parenchyma. And these are the immunohistochemical profile. Case 14. A very cellular aspirate, and you are seeing these discohesive clusters of blunt-ended spindle cell nuclei, and hardly any cytoplasm. Again, no amyloid, no features which were suggestive of MTC. We called it category 6. We didn't have, so similar workup was done, which was all negative. So this was interestingly a lady who had a history of hysterectomy done in private. We didn't have any records. Interestingly, when we searched our records, we found that there was a liver biopsy sent almost at the same time, and it had a metastatic leiomyosarcoma. So in hindsight, we put everything together. So it had also metastasized to the thyroid. A rare presentation, but that was the case. The take-home message is most spindle cell aspirates will be MTC, but not all of them. So in case you are not seeing calcitonin immunoreactivity, serum calcitonin levels are normal, you need to follow up, or you need to, so cell blocks often help. So other spindle cell lesions of thyroid, what all you need to consider? Anaplastic thyroid carcinoma, spindle cell variant of PTC. So do look for nuclear features. PTC with nodular fasciitis or fibromatosis like stroma. This was an important differential in the case which of fibromatosis of thyroid, because in these cases, the PTC component may be very small. It may not be aspirated. It may be even difficult to find it on histopath. So you need to sample a lot to rule out PTC. Renal thyroiditis, solitary fibrous tumor, post-FNA or biopsy spindle cell artifact, peripheral nerve sheath tumor, and a spindle cell follicular adenoma and carcinoma. So main differentials, spindle cell PTC, don't miss it. MTC, of course, I'm sure none of you will miss it. Spindle cell follicular adenoma and carcinoma. So these are the, which are like, we know that they can occur commonly in thyroid. Rest all you also need to keep in mind. Case number 15. So I think one of you needs to take this up. This is an interesting common case. I should not say interesting, maybe a common case. So what we were seeing was
from this side. Would you like to participate? This side? No? Anybody?
Only 2 more cases and they are very easy. Okay. Arey beta, pura describe to karne do. That will help you. So a very cellular aspect, what we are seeing are mainly oncocytic cells. So as per the new WHI, we have stopped calling anything hurdle, as sir described yesterday, and we call them oncocytic cells. So predominantly oncocyte-rich aspirates. The nuclei were predominantly large, but they were enlarged. They were predominantly round, but they were large in size. And you can see multiple intranuclear inclusions. So this one has single, this one has 4, this has like a double inclusion. There were numerous intranuclear inclusions. So now what do you want to call it? Beta, there are no lymphocytes. It's a very cellular aspirate, no colloid. So what will you call it? Tell me the Bethesda. Did you see true papillae? Did you see stemoma? No. So I told you even oncocytes can show inclusions, but I agree with you, not so many. Okay, so this was a case of oncocytic PTC. You can call it 5 or 6, depending upon the severity of the nuclear features. But you should always remember that oncocytic PTC does not show true papillae. It may show, I'm not saying it, I should not say it does not show, but usually it does not show. It does not show the typical nuclear overlapping. Why? Because these have abundant cytoplasm. So the cytoplasm keeps the nuclei away and they don't overlap much. The nuclei are predominantly round. But don't remember, oncocytes can also show occasional inclusion. And I have also made a mistake. I have called something PTC when it turned out to be an oncocytic adenoma. Luckily for me, there was a microcarcinoma lying nearby and it saved my skin. So there are the oncocytes are prominent diagnostic pitfalls, but this was a case of oncocytic PTC. So all aspirates with oncocytic cells are not oncocytic neoplasms. You can see the oncocytic change in Adrenomatous Goiter, in Hashimoto thyroiditis, in an oncocytic adenoma. In Hashimoto thyroiditis, a predominant oncocytic nodule may be there. Oncocytic PTC, tall cell PTC, Vardin-like subtype of papillary thyroid carcinoma, oncocytic MTC. So you can see them in a number of cases, and depending upon what you are seeing, the Bethesda will be decided like that. So for example, this was an aspirate in which predominantly we got oncocytic cells, but there were interspersed small lymphocytes. Clinical history was suggestive of Hashi, so we call it category 3, AUSH. This was a hypocellular aspirate, but we got these oncocytes. There was nothing else in the background. Again, we called it AUSH because it was hypocellular. This was the case which we just saw. We call it category 5, highly suspicious for PTC, and it turned out to be oncocytic PTC. This was a case of oncocytic MTC, medullary thyroid carcinoma, which showed oncocytic change. It was very this thing, and in this case, we did see the azurophilic granules. You can see one over here, plus this abrupt nuclear pleomorphism and multinucleation, and we did calcitonin immunocytochemistry, which was positive. So depending upon what you are seeing and ancillary findings plus ultrasound and clinical, you can make the Bethesda classification better. Last case, a cellular aspirate. You are seeing predominantly lymphoid cells, no thyroid follicular cells. There is an admixture of mature and immature, but there is an immature lymphoid cell preponderance. Anybody? So category? 6. I told there is an admixture beta. So admixture, your differentials are non-Hodgkin lymphoma, as you said, category 6, or it can be Hashimoto. So when there is a lymphoid follicle formation and you tend to hit with your needle the center or the follicle center, you will get predominance of immunoblast, centrocyte, and centroblast. This case turned out to be DLBCL. So you are actually right. But when you get, you have to see the entire thing into picture. You do need radiology if you get a mixed cell type aspirate. So aspirate from lymphoid follicle center can mimic NHL, high grade. So this is a pitfall. So these are my references. The take home messages: thyroid FNA is challenging. There are multiple potential diagnostic pitfalls. I have not covered all of them. So there are multiple more. For example, abundant colloid, don't call it category 2 till the ultrasound also is suggestive of a colloid nodule. And awareness of these pitfalls, along with careful attention to cytological, clinical, and ultrasound features, as well as use of ancillary studies, can help in reducing errors, as well as giving a better Bethesda classification and a guide to the clinicians of how to manage the patient. Thank you.
Any questions from the audience regarding the cases that we have discussed? Yeah, please.
Since it's a very interesting topic, and I would like to discuss 2 more conditions which could have probably people can see in their practices, and it often causes a diagnostic pitfall. One is cystic PTC being diagnosed as a follicular nodule. It happens commonly because in that scenario, what happens is that the individual lying atypical cell, it imbibes colloid, and sometimes it starts giving an impression of macrophages. So thinking about means taking a history, a rapidly increasing nodule or a nodule with a shorter history would help in such a situation. And if there is a situation in which there is a long-term progressive increase, then our thinking perspective might change. Second scenario is many a time lymphocytic thyroiditis or Hashimoto's thyroiditis can be misdiagnosed as Hürthle cell neoplasm, because sometimes prominent Hürthle cell nodules tend to develop, and if I maybe hit that position, and then we tend to get more than 75% cells. So again, that is one of the pitfalls that can be seen. Another thing that I would like to mention is that seeing the background picture of the cell is also quite important. When you tend to see different types of cell, for example, macrophages are there, a small cluster of Hürthle cell is there. Apart from that, there is a lot of cellularity with papillary fragment. Then instead of thinking it of maybe as a category 4, somewhere in the mind, adenomatous nodule should be there. So, and nuclear grooving, what I think is not a confirmatory feature of a PTC. Presence of a number of inclusion is a definitive help, but in nuclear grooving can be seen in benign conditions like colloid nodule. It can be seen in neoplastic benign conditions like follicular adenoma and manium.
Inclusions, many artifacts can look like inclusion, which has to be kept in mind.
So the color of the inclusion matter. If the color of the inclusion is similar to the cytoplasm that we are seeing, then possibly it could help in saying us that it is a true pseudo inclusion.
So this is a picture from one of
Thank you so much
I love
for adding so many pitfalls. Enjoyed that. I think anybody else want to ask something? Yes, please.
Dr. Shipra, very good cases.
Thank you,
The
ma'am.
last case, did this patient have enlarged lymph nodes also, the lymphoma?
No. He
It was
didn't have
just,
lymph nodes.
uh,
It was a primary
thyroid
thyroid DLBCL, yes.
And did they take a core biopsy from the thyroid?
After this, yes. So when we called it category 3, I went back to the clinician and they reviewed it and they did subject the patient to a two-cut biopsy.
Yeah, thyroid is the only organ where a core biopsy is taken when an anaplastic is suspected and when a lymphoma is suspected.
Very true.
So thank you, Dr. Shipra,
Thank you, ma'am.
for such an interactive session. And I think it is beneficial for our residents as well as the faculty present here. Thank you so much.
Thank you. And I'm sure all the pitfalls can be sorted out by molecular, which ma'am is going to cover, Dr. Radhika. Thank you, ma'am.
Thank you so much, Dr. Shipra ma'am, for clearing our concept. It will definitely help us in future.
Moving the session ahead, I am very delighted to invite our chairperson of talk entitled as Molecular and Ancillary Techniques in Endocrine Organ Cytology, Professor Arvind Rajvanshi sir from the Department of Pathology. He is Executive Director of AIIMS Raebareli.
And Professor Ramnath sir from Department of Pathology, SGPJIMS. He has more than 80 national and international publications.
To kindly come upon this dais.
I request Dr. Arvind Rajvanshi sir, kindly please introduce our speaker of this session, Dr. Radhika Srinivasan ma'am.
Professor Radhika Srinivasan is a head of the Department of Cytology and Gynecology and Pathology at IIT Chandigarh. Her main areas of interest are cytopathology, gynecological pathology, and molecular pathology. She is a member of various professional bodies like American Association for Cancer Research, Indian Association of Cancer Research, Indian Association of Gynecologic Oncology. She has many achievements in the world. National Talent Search Examination for Merit Certificate and Scholarship, Mysore Medical College Silver Jubilee Prize, Commonwealth Scholarship Award, multiple national and international publications. I invite Dr. Radhika to deliver the talk.
Thank you so much, sir. It's really an honor to be giving the talk in the presence of our teacher, Professor Rajvanshi. At the very outset, I'd like to thank Dr. Manoj Jain, Dr. Vinita for inviting me to this meeting, and also the IAPID executive, Dr. Kuto, Dr. Rini Malik, and Dr. Anita. Thank you for at least including cytopathology as a couple of talks at least in this large meeting on endocrine. And so wherever applicable, I think they should be also included because it's part of the practice of pathology, I would say. And actually, when I said yes to Dr. Manoj Jain about 4-5 months ago, he just told me thyroid ka molecular aap cover kar denge. I said okay, I'll cover it. So I kept on thinking that all I have to do is to talk on thyroid molecular stuff. But 2 weeks ago, when I actually saw the letter and saw what is the topic, the flyer assigned to me. It said endocrine organ cytopathology, molecular and ancillary techniques. And that gave me a lot of, kind of a shock. And how I said, how can I cover this in the next half an hour or 40 minutes? So all I can do is सिर्फ झलक दिखा सकते, एक ट्रेलर दे सकते, movie अभी बाकी है. So with that, so this is what it is. I'll just stick to mostly the thyroid, briefly touch upon pancreas, adrenals, and of course only the neoplastic lesions. We all know this ancillary technique is IHC, and we had this beautiful talk in the morning about hormone-specific, the role in pituitary, but that goes for a lot of endocrine organs. But we know we have the broad markers, chromogranin, synaptophysin, of course, INSM1, and I have blocked that NAC. That is something so many people use, but that is so non-specific, that it is best if it is not there in your panel at all. Please stop. If anyone's using NSC, please stop using it. So of course, pancreas, we have EUS or transabdominal, and you have the DDs of a pancreatic sol, and we'll look at some examples of NETs. So yeah, even in pituitary adenomas, we saw that they stopped calling adenoma. It's now on the era of NETs, that is the neuronet or the neuroendocrine tumors. And these are some of the general cytopathological features of NET. All of us know this. I don't have to tell this to this audience. Dispersed population, anisonucleosis, some binucleation, salt and pepper chromatin, plasmacytoid cells, granulation. Sometimes you can find also this kind of amyloid-like material. You also can have very cellular aspirates, nice loose aggregates like that, forming these so-called pseudo-SNR pattern, and of course with a fine chromatin. So just like you have in histopathology, organoid patterns, festoons, trabeculae, etc., you have very well-defined cytopathological features of NET that is so you can diagnose with a great degree of accuracy. But yes, like I said, ancillary techniques is what I have to talk about. So here was a small pancreatic sol, 1.6 into 1 centimeters. And this was what we had. We had a nice cell block with us, and we applied chromogranin. And of course, we also do a Ki67. So unlike in histopathology, where you would go do mitotic counting, we find Ki67 very helpful, but you should have a very nice cellular cell block. You should have good fragments. You should be able to, count a good number of nuclei, at least 500 nuclei. And then, of course, you can give the Ki67 index. And this was one low Ki67, less than 2% or whatever. So it was in the grade 1 NET. So here is another case, which is very common in clinical practice. So instead of the primary, you get liver metastasis. Again, no problem in calling a neuroendocrine tumor based on morphology there. But we had again a cell block. And then, of course, we applied the chromosynapto. And here, in this case, the Ki67 was, something around 8% that gave us a diagnosis of grade 2 NET. Subsequently, of course, a primary was detected in the pancreas. So this was there, metastatic NET in the liver. Here is another case of a pancreatic sol. Of course, now this is compared to the previous two, is showing you high-grade features. Okay. Obviously, no problem. You have high NC ratio, very coarse chromatin, this kind of, crushed artifacts, nuclear molding. So absolutely no problem in calling this, or even on morphology, as a small cell neuroendocrine carcinoma. But just to show you and to complete the picture, this was positive for the neuroendocrine markers, chromogranin and synapto. Cytokeratin showed this kind of a dot-like positivity, which comes in NETs. And of course, it was having a very, very high Ki67 index. So this was, again, in the liver sol, of course, primary in the pancreas, small cell neuroendocrine carcinoma metastasis. So this is another case, EUSFNE, pancreatic sol, obviously neuroendocrine tumor there. And just to show you that in this case, which applied INSM1 on the cell block. So this is, again, a very good marker if you have less material. And there are some papers, I think, from AIMS in the context of lung NETs, that you could also do this INSM1 on smears. If you didn't have a cell block, it's better to do an INSM1 on the smear and show that it is of neuroendocrine origin. Now, this was another case which we were very confident on morphology that this is a neuroendocrine tumor. It had all the features that I described to you. But this is what the cell block, it showed something funny. We were seeing some sort of a nice acini, some strips like this, and this was what, there was a bit of desmoplastic fragment or whatever in the cell block that said there's something odd for an NET. And when we did the immunos, it turned out to be an acinar cell carcinoma, negative for chromosynaptone, positive for CK7-19, and the specific marker that is trypsin, and also BCL10 is another marker which you could also apply. And another DD is the pseudo-papillary tumor with this Chinese letter pattern. And of course, you have these individual cells can simulate an NET, but this is a publication from our department, and we have positivity in the cell block for vimentin, PR, CD10, and nucleocytoplasmic beta-catenin, which gives you the confirmation that you are dealing with a solid pseudo-papillary tumor of the pancreas, which is a close mimic of pancreatic NETs. So with this, we move on to a couple of adrenal lesions. Again, this is, like I said, just to complete the topic assigned to me. A case of adrenal pheo, normally you don't want to put a needle if it's a proven pheochromocytoma, but sometimes the radiology in the clinical picture can be equivocal, and you can get these aspirates. You have this typical, dispersed population or loose aggregates, some perivascular arrangement, syncytial kind of arrangement, abundant this kind of cytoplasmic granulation. And so this was a straightforward case. But here was a case of a patient of MEN2, and he had a proven MTC, medullary thyroid carcinoma and pheochromocytoma, presented with a liver sol. It had a metastasis, and this is the morphology there. So any guesses from where is this metastasis from? From MTC or from pheochromocytoma? Anybody? MTC, you think because of this fine pin granulation, but that can also be seen in a pheo. So it's very difficult in this situation, and that is where making a cell block is so important. I mean, at least in our department, since the days of Sir also, we have always done a cell block for more than 2 decades, I think almost now, that whenever we do an FNAC, almost invariably there's an accompanying cell block. And I think our success rate as far as cell blocks are concerned from FNAs, we haven't really gone and looked at it, but generally I can say to the extent of 80 to 85%, we get decent cell blocks, and quite cellular ones in more than 50% of the cases. So here we had the cell block, and again, it was negative for thyrocalcitonin. So this was proven to be a metastasis from the pheochromocytoma. It was so important from the clinical management perspective. And again, just to complete the picture, like I said, this was a case of an aspirate from an adrenocortical carcinoma, dispersed population of cells, very large cells with the anisonucleosis, bubbly cytoplasm. You can have the differential diagnosis of a renal cell carcinoma, a metastasis into the adrenals, and also a pheochromocytoma. But again, a cell block would solve the problems, negative for the RCC markers, positive here for inhibin, and you can give a confident diagnosis of adrenocortical carcinoma. So with this, we move on to the thyroid, which is the most important focus, I think, of this talk. We discussed a lot of thyroid whole of yesterday, a lot of histopathology of the thyroid. But actually, we put in the needle first, isn't it? We provide the pre-surgical diagnosis as cytopathologists. Unless we do the FNAC and give a report, the surgeon is not going to take out the thyroid for the histopathologist to see. So sometimes I thought, okay, this cytopathology talk should come before histo, but then, there's another side to it, that you can't interpret cytopathology unless you know the histopathology well. So it's only with the background knowledge of histopathology that you can actually go and interpret. So I think it's very appropriate that we came later after the histopathologists have done their job. So here it is. So we know that it's a well-established technique for the pre-surgical diagnosis, and it helps triage the patient appropriately. So our job is to tell them, is it neoplastic? Is it non-neoplastic? Second is in neoplastic lesions, of course, if it is benign, they will do a certain type of surgery, lobectomy. If it's malignant, it's a total thyroidectomy. But very important is this distinction from non-neoplastic and neoplastic, because in non-neoplastic, the patient could just be observed, or sometimes for other reasons, they may still go and operate the patient. And then came this, the Bethesda system. All of us are talking about it, of course. It's almost 12-year-old. The first edition came in 2017. The revision has come in 2017. We know the 6 diagnostic categories, and Shipra did a wonderful job of showing the diagnostic challenges and the pitfalls. But just remember that in spite of all the challenges and all the pitfalls, we have a wonderful diagnostic accuracy. Otherwise, it would not have stood the test of time. FNA thyroid has stood the test of time, which means that its diagnostic accuracy is quite high, well over 80% would be. So the pitfalls are actually in, the 10%, 8 to 10% of the cases where you can have both false negative and false positive diagnosis. So we have all this category 1 to 6, and we know that what is very important for us to understand is the risk of malignancy. Okay, we know that from CAT 2 to 3, 4, 5, 6, the risk of malignancy increases. And there's also, depending on the risk of malignancy, you have the concern management, which could be just follow-up for a CAT 2. For CAT 3, we have different options, which is repeat FNA, we'll see later. For CAT 4, it is lobectomy, and for CAT 5 and 6, it could be near total thyroidectomy. And this is the biggest challenge, which Shipra covered a lot of CAT 3 cases, which we used to call as OS/FLUS. And then in the revised Bethesda, they said call it OS and tell it. And this really represents the major challenge in thyroid FNA cytodiagnosis. And this was our paper when we estimated our risk of malignancy and risk of neoplasia in overall, and also in the Bethesda indeterminate categories. This was published way back in 2017. And of course, even at that time, we had said that this was before the actual Bethesda actually made that recommendation of subcategorization of AUS. We said that you could subcategorize them, and I'll show you pictures of the same. So for example, this was OS-NOS, this was OS-Hürthle cell type, okay, where it had a predominance of Hürthle cells. And we always, at the time of reporting, we used to tell the differential diagnosis could be Hürthle cell hyperplasia in the context of lymphocytic thyroiditis. Hürthle cell neoplasm is not excluded. So we would put this in our reports. You see, that is very important rather than simply, telling OS, HC and things like that. And then I still like this FLUS. Because why you want to call OS architectural ATP? I know that the Bethesda has gone and made this change, but personally, I mean, our clinicians and even I personally like FLUS. It's a follicular lesion. Of course, you can have differential diagnosis. This is what we would call it as FLUS. That is FH, favor hyperplasia, because it has all these kind of, resorption vacuoles, fire flare, etc. Here is a FLUS of the HC type and Hürthle cell type. And then here is a FLUS where, it had microfollicles, incomplete features of PTC, PTC not excluded. So this is how we were practicing, and we continue to do this also, although we do follow the Bethesda. And when we look at the indeterminate thyroid nodule, it represents together category 3, 4, and 5. Together are called the indeterminate thyroid nodule. So in our study, it was, there was a time trend. Over time, we saw a slight increase in the number of these indeterminate thyroid nodules, but generally it's around 8 to 10% of all thyroid FNA. And if you look at the atypical, that is only the CAT 3, this is in blue, it was hovering around 5% of all aspirates in the year 2015. Maybe it has slightly increased now because of the increased usage of ultrasound, and we're getting more and more ultrasound guided FNAs from smaller and smaller thyroid nodules, and that can increase your AUS rates actually. And I draw your attention to this very nice meta-analysis by Shipra. The Indian experience of OS+ is different from the rest of Asia and the West, a systematic review and meta-analysis. And this is a very nice analysis, and it has compared 18 Indian studies, 12 Asian, and 30 Western. Now, we are always, we are deluged by data from the West, actually, that most of us stop seeing Indian data and stop seeing even data in the rest of the world, like Japan and Australia, etc. Also, they have their own figures. And this is where I would say you need to do these kind of studies, systematic reviews, meta-analysis. And what the bottom line that was drawn from this study was that the pooled prevalence rate was somewhere around 7.3%. The pooled estimates of AUS was around 7.3%, which is not different from India and also the other regions. But the risk of malignancy was very high in the Asian countries and lowest in the West. So the risk of malignancy in the West is somewhere around 25 or 26%. In our case, in PGI study, it was 50%, and in Asia, something around 45%. Now, why does this change happen? The risk of malignancy is different it can be different in your own center. So you need to do your own analysis. Institutional analysis has to be carried out before you kind of know how should the surgeon. Now, the surgeon is not going to operate each minute you write a category 3 report. The surgeon is not going to operate. So they're going to have some other parameters, and then so they themselves will select certain cases for surgical, either a lobectomy or something they would select. So there is a kind of a selection bias, but we really haven't gone into the details of what makes the surgeon do a lobectomy when we send out a report of AUS, but that is again an evolving field. So if we come to the Bethesda 2017, they went, if you look at the indeterminate categories, you can see that you have 3 options. You do a repeat FNA, you do a molecular testing, or you do a lobectomy. Category 4, you do molecular testing, and of course, they have said for category 5, nothing at all. The surgeon can go and operate. But just yesterday, while the session was going on, I had signed out one report as category 5. The patient turned out to be a VIP or whatever. And the surgeon calls me and says, Dr. Radhika, can you please review this slide? You have called it out as category 5, and I can't operate if it's category 5. I said, look here, the Bethesda says you can operate, and I have my limitations. I call it category 5 when there's something that's forcing me to call it 5. I wouldn't have. I would have been very happy to have all the material to call it a frank papillary thyroid carcinoma, but there was some limitation, which is why I put it into category 5, and we do cross consultation. We show it to others in the department, and this was a consensus. But that is where the dilemma comes, that not every surgeon would go and even operate. In our institution, they want a category 6 report before this. And I started giving me a lecture on the complications of thyroidectomy, lifelong L-toxin, hypoparathyroidism, etc., etc. I said, I'm fully aware of all that, Dr. Saab, but you see, I have my limitations. But then that's how it goes, So, but look at this. So you can go repeat FNA or a molecular testing. So let's look at the ancillary technique to improve our diagnostic accuracy. So we have, of course, immunocytochemistry, like I said, we have molecular testing, but this is our real thing that we need as pathologists to understand thyroid imaging or thyroids. In fact, now, when a patient walks into, when we do palpation guided FNACs in most of the cases, and the proportion goes for ultrasound guided FNACs. But irrespective of the fact that even if you're doing the palpation guided FNA, you must ask the patient, ultrasound hua hai? 90% would have had an ultrasound with them. Please check the report of the ultrasound and note down the points. You need to have some basic knowledge of that. And of course, in molecular testing, we'll look at all these in greater detail. And I'll show you a bit of a thyroid IHC there. So this is the thyroid scoring. They will give up 0, 1, 2 scoring, cystic, solid, cystic, echogenicity, anechoic, hyperechoic, hypoechoic, and very hypoechoic. Then we have shape, taller than wider, wider than taller than wider, of course, is significant. The margins, and also they give a score, and thyroids 1 to 5, and then of course what is benign, and of course 4 and 5 are highly suspicious. So this is how it is. So they will do an FNA in 3, 4, and 5, and this is the risk of malignancy based on the thyroid score. So I think your first important ancillary investigation in thyroid is ultrasonography. That is the message I want to give. Please look at the ultrasound yourself and start looking at, just don't simply see thyroids kya hai. Read the report. See if there's macrocalcification. What's the vascularity? Is it hypoechoic? Then your antenna should be up. Okay. So this is very important. I don't have time to show you all ultrasound images because that's not the theme of this talk, but that's very important. look at what about IHC for thyroid lesion? Should we do a cell block in all cases when there is suspected thyroid neoplasia? Well, I'd say its big role is in the detection of metastasis from well-differentiated thyroid carcinoma. And as far as its role in primary thyroid neoplasms, let me just show you the data, whether it's useful in this context of diagnosis, is it useful in the context of predictive markers. Here is again a very, very recent case, just signed out a couple of days ago, 68-year-old lady, and she comes with this frontotemporal lesion, a lytic lesion was detected. And this was the FNAC that was done from this lytic lesion. And actually, according to somehow from the radiology, I don't know why, but they had written on the form query meningioma. Okay, so, but this is what we had it, and it was all epithelial looking. The cytopathologist reported simply as a neoplastic lesion. It was not further categorized, and a biopsy was then taken from this lesion. And I think the histopathologist had no problem whatsoever in calling it what? Yeah, it's got nice, you see, macro follicles, not necessarily micro follicles. And we have Dr. Bishan also here in the audience. We have Uma. Yes, would you, maybe they signed it out as metastatic follicular carcinoma only, but yes, of course, you know, again, the clinicians force you to do IHC, even though the morphology is so classical. It was, of course, positive for TTF1 and thyroglobulin and all that. So then it came up, they did a further workup, they found these, this is the nodule in the right lobe of the thyroid. Can you see the arrow? Yeah. And so when they did this ultrasonography, they now have this nice nodule in the thyroid, well circumscribed, few hypoechoic internal areas, taller than wider. Then they said it is thyroids 5. And this is the needle in the lesion, ultrasound guided FNA done. And so then we look back, and in fact, this patient had had 2 previous FNACs from the thyroid, and both had been reported by us only as category 3. And why? Because of this technical reason, you know, diluted, aspirate was diluted, there were low cellularity, and then somewhere we saw a few microfollicles there, so not very conclusive. So it was, and rest of the history was not known, that whatever was not known. And we did have for some reason, a cell block had also been taken at that time, but nothing had been done further. So then came the current FNA, which was absolutely cellular. And I mean, this was done by the senior resident, Dr. Eljiva, who is a former resident of SGPGI. You can be very proud of her. And then she had beautiful smears, and you know, it was obviously obvious to us, it's a follicular neoplasm. Now, the classic teaching is in category 4 follicular neoplasm, cytology cannot differentiate between follicular adenoma versus carcinoma because you need to demonstrate all that invasion, etc., etc. But here you have a patient with a metastasis, so there's no problem in calling this follicular carcinoma. So when retrospectively we went back to our cell block, which we had just signed out as neoplasm, and that showed positivity for TG. And the reason I think that follicular carcinoma was missed, in fact, we have a lot of cases where we have diagnosed metastatic follicular carcinoma, metastasis from the thyroid, but here somehow the microfollicles did not predominate. The smear was a little paucicellular, you know, technically not a very great aspirate. That's why we had missed the case, but it was positive. We could have picked it up retrospectively. Here's another neoplasm of the thyroid. So again, another maybe, what would you call it? I don't know. So it had some follicles, some grooving, some dispersed cells, maybe query inclusion. Is it PTC? Is it a follicular neoplasm? Is it query NPC? So any guesses? Just, I mean, it's not fair to ask the audience to guess on a single image, but this is what it is. It came out positive for thyrocalcitonin. So sometimes, you know, doing IHC and having a cell block in a case of a neoplastic lesion does help you resolve the case. We had a study, again, this was a thesis of my student nearly 5-6 years ago, where we looked at thyroid FNA cell blocks, and we looked at 3 markers, galectin-3, HbME1, and we did not look at CK19, but that is the third marker that people use in the context of thyroid primary neoplasms. So just to show you that they can show concordant staining, this is discordance, but sometimes this is also concordant negative, this is concordant positive in a case of PTC, and this is sometimes GAL3 comes and HbME is negative. So this is what we saw. And then just to show you some cases, this was a case of AUS. Now, currently you can call it as Psi-A, cytological atypia, where PTC is not excluded. So it came out positive, and follow-up histopathology confirmed it to be a PTC. So very nice, very happy, both of that worked. Here was a case which we thought it was a follicular variant of PTC, which came negative on both the immunostains and turned out to be an FV PTC, I think. This was one. So basically, there have been, if you go back into literature and look at, there are a lot of Italian studies which show very high sensitivity and specificity for IHC using these markers, but this could not be corroborated in many centers, and this is definitely not the acceptable now because of low sensitivity and specificity in the context of intermediate thyroid nodules. In a frank case, it may help you. So, but IHC is useful. I've already shown you all these two situations. And what about BRAF? V600E positivity, is it useful? Well, we know this is the mutant, IHC for mutant BRAF clone V1, widely now used by all histopathologists. And it shows an excellent concordance with the mutational status in PTC. So basically, as far as histopath sections post-surgery, it is really good. You can use it as a surrogate marker for, BRAF V600E. But when it comes to cytological specimens, this is one study. So we haven't done an actual detailed study. Sometimes we have used it, but it can have problems. Then in this particular study, they found that the sensitivity and specificity of this IHC for this mutation was only 77%, and specificity was also low as compared to a higher sensitivity in CND samples. So it's in FNA samples, it's of limited value compared to molecular testing. But again, that's probably not the last word. That's one study. So with this, I'll spend the next few minutes on molecular testing in thyroid FNA. And I just put this especially for the residents. So molecular testing, you can go and read this very nice review article there. And so this, you have to understand that all the mutations are in this MAP kinase cascade pathway. So here you have the growth factor, the receptor tyrosine kinase, the red PTC here, which triggers RAS, RAF, BRAF, MET, and ERK, and which regulate gene expression, leading to uncontrolled cellular proliferation, increased cell survival, invasion and metastasis. And we have the PIT-AKT pathway also, which is triggered on by RAS. And then also here comes the role of PTEN as a tumor suppressor gene, which is in turn regulated by PAX8, PPAR gamma. So you have the red PTC gene fusions there, which affect here. At this point, you have the PAX8, PPAR gamma. Here you have the RAS and BRAF, which have the activating oncogenic mutations. But what is the frequency of mutation in thyroid neoplasms? BRAF, again, it differs. If you look at some Korean studies, the mutation frequency is nearly 80-85%. But in general, this is the rate, 40 to 45% is the BRAF positivity, red PTC 10 to 20%, and RAS in about 10 to 20% of the cases. So what are the platforms available for molecular testing? So one is Thyroseq NGS. And so basically this incorporating the new information obtained through TCGA, the Cancer Genome Atlas, the NGS for this thyroid nodules was devised. And it uses both DNA and RNA based next generation sequencing, 112 genes, looks for everything, point mutations, indels, gene fusions, and all that. So these are the genes, BRAF, RAS, TERT, DICER1, NTRK1, 3, BRAF, RET fusions, excellent. And in the FNA validation set, the sensitivity was 98%, specificity 81% with a very high accuracy. And what is very impressive about Thyroseq version 3, the latest version, is that it can work with input nucleic acids as low as 2.5 nanograms, but it needs at least a 12% concentration of tumor cells. Then we have the next platform, which is the Afirma gene expression classifier and the gene sequencing classifier GEC and GSC. This was developed through an iterative process to have a high sensitivity and a high NPV because what they wanted to do was to distinguish between the benign, the non-neoplastic from the neoplastic. So they wanted a high NPV. So this was developed to potentially decrease the rate of diagnostic surgeries in the case of indeterminate nodules and nodules diagnosed benign on cytology. So, so therefore, this again has had a decent result. And this is just to show you, taken from this paper, of course, in how you can have informed clinical decision making from a single FNA sample. The Afirma really helps. For example, this particular nodule got classified as a neoplastic nodule by using this Afirma platform. So then we have the third kid on the block is microRNA profiling. There again, you have these companies which have come up with Thyroidectomy and Rosetta GX. And the Thyroidectomy again has a very high sensitivity and specificity. But if you look at the Rosetta GX renal assay, what is its UPS is that it uses these stained FNAC smears from where the RNA is extracted. It measures 24 microRNAs, and the assay performance, they say in this may vary based on the accuracy of the histopathology results as well. So I was reading one of the papers of this Rosetta GX, and they said that based on the results of this, they went back and got a revised diagnosis of histopathology from the upon expert review. So this can also happen, something that has been called out maybe in routine by a routine surgical pathologist as follicular adenoma may on expert review turn out to be, follicular variant of PTC and so on and so on, or an IFP. So these are all follicular pattern lesions we all know is a problem, and so much of time has been devoted on them. So how does one interpret diagnostic test accuracy? I just want you people also to have this concept that when we are talking of PPVs and NPVs, it is important for you to know the institutional prevalence of cancers. So if you're in a region which has a high prevalence of thyroid cancer, your PPV will be high. Okay, but if the prevalence is low, then your PPV can be low. So basically, you see the formulas for PPV and NPV also incorporate prevalence. So that is very important as a concept. And as a general rule, we know that when you increase the sensitivity, that tends to reduce specificity and vice versa. The second concept that Dr. Neeraj yesterday in the panel discussion she made was this concept of what is a rule-in test, what is a rule-out test. Rule-in means the patient, if the test comes positive, you are ruling it in, patient can be taken up for surgery, for the appropriate surgery, lobectomy or whatever. Rule out means it's most likely benign. You are ruling out surgery. So this again, when you read articles, this is what you see, rule-in test, rule-out test. And this again from this very nice review article published in Cancer 2018. So they looked at the sensitivity. So you see the specificity. So this is rule-in. If you want a rule-in, you want a high PPV and a high specificity. And if you look at that, Afirma fails here. Rosetta is very not average, but this Thyroidectomy and Thyroidectomy have very good, this is 92%, this is somewhere around 80% specificity, and the PPV 68%, something like 77%. And this is an old article by in 2011 published, the so-called 7-gene mutational panel, but now they don't talk about it anymore. Now, if you look at rule-out testing, that is where your Afirma actually performs well with a high sensitivity and a high negative predictive value, but these also perform equally well, that is Thyroidectomy and Thyroidectomy. So if you look at these two are having good rule-in as well as good rule-out. Afirma is a good rule-out test. So if you look at BRAF mutations in thyroid cancer, sir, how much time do I have now? If you can, 5 more minutes. So if you look at BRAF mutations, we know that it's V600E. I've also said, besides that, you also have the K601E mutation. Point mutations are most common. The clinical implications are that it's a specific marker of PTC because BRAF is not seen in other mutation types, of course, with the exception of anaplastic and some poorly differentiated thyroid cancers, which take the BRAF pathway, So it's seen in about 10 to 20% of these cancers, indicating that it's an early event in tumorigenesis. Prognostic implications, again, yesterday in the panel discussion, is a marker of poor prognosis, extrathyroidal extension, advanced stage, lymph nodal metastasis. Even in T1 carcinomas, BRAF is strongly associated with lymph node mets and extrathyroidal extension. So if you detect BRAF preoperatively in the FNA samples, the surgeon can plan a more extensive surgery, a closer follow-up, and probably can also predict for radioiodine resistance, and so on and so forth. As far as RAS gene mutations are concerned, this is the percentages, but remember that RAS mutation comes up in both adenomas and carcinomas. It marks neoplasia, but not malignancies. As far as third gene mutations are concerned, we discussed this yesterday again in the panel discussion there. Third genes are always associated with unfavorable outcomes. Now, there in one of the recent studies, they have found that it is, and I think there's been a meta-analysis again, they've been found in about 7 to 22% of PTCs and 14 to 17% of FTC, but it's much higher in the dedifferentiated thyroid cancers. So essentially, TERT mutations are an independent predictor of disease-free survival and mortality. So that is where TERT stands. Now, this is another study from the Koreans, actually, where they looked at the prevalence of TERT mutations, and again, they were correlating it to aggressive histological type, poorly differentiated thyroid cancers, anaplastic thyroid cancers, and actually, these are 2-point mutations, C250T and C228T. Individual, this is more common, but they did not find a significant difference in their population. So very quickly, what should be the sample for molecular testing? Directly collected sample, you have cell block, you have smears. Each of them have their advantages. Here in a directly collected sample, it's ideal, but the cellularity and adequacy can never be assured. Cell blocks is from thyroid, you can get it to work even in the best of hands in 40-50% of the cases. In indeterminate thyroid nodules, you'll hardly find any material in the cell block. Smears are excellent, cellularity and representation is assured, excellent for DNA-based assays, but it's okay for RNA-based assays. This is just what we do, cell scrapes, we take it in and append off. Similarly, cell blocks can be taken, and then you do the QIAGEN simple protocol. This was the DNA yield in all our cases. When we compared a direct sample to the cell scrapes, obviously the cell scrapes had a higher median level, nearly 2-fold increase in the DNA extracted, and of course of excellent quality. So this is, again, I've already talked to you about this, so we will skip the slide. So I'll quickly take you through the preliminary, the publication we have on this endogen thyroid mutation kit 5-gene assay, RAF, RAS, NRAS, and HRAS. Remember that in thyroid, when we're talking of RAS mutations, it's NRAS and HRAS, which are more common, and not KRAS. KRAS is very, very uncommon. So this is what the whole setup is, simple real-time PCR, and you read out against the internal controls, which are the Ihc, and you have, this is the test, which is the FAM. So sometimes you can get problems when you have all internal controls may not work. You have this, something going up and down. You can't, this is an uninterpretable test. Sometimes you get a low rise, which is not good at all. I'll just show you a few cases. Typical case of papillary thyroid carcinoma, nice BRAF positivity there. Again, another case of PTC, BRAF positive there. Here is a case of follicular lesion. It was category 3. We got a very nice NRAS, and then it turned out to be a follicular adenoma there. Here was in a lymph nodal metastasis. So this was all mutations were negative, and this turned out to be FVPTC. So it doesn't help you in all cases. So you should know the limitations of the test as well. And then, of course, here was an FVPTC. We suspected, of course, but BRAF was nicely positive in this. And of course, this was a follicular carcinoma, which was put into category 4, follicular neoplasm, which showed us HRAS positivity and turned out to be a follicular carcinoma. So here was another case, which was an FVPTC, which showed NRAS positivity there. And here was a poorly differentiated carcinoma, which was NRAS positive. So this is the publication we got from this, which is published in the Journal of Cytology. my just appeal to you is you must also quote Indian studies, which are there and which have got out some data like this. Of course, this was a single center. It had limitations in small number of cases, but this was a pilot study, and this is the first study from FNA samples. So then we have shown it that we have used cytoscrapes, and basically this was the mutational profile. We could see it in nearly 55% BRAF and NRAS in 26 and 23% of the cases respectively. When you look at OS plus, NRAS turns out to be the most common mutation in the category 3, and in category 4 you had both a few HRAS and a few NRAS coming up there, and so also in category 5. And so this is the composite pie chart in the indeterminate category, 24 cases where NRAS was seen in 30% of the cases, followed by HRAS and also BRAF. So I don't have time for that, but especially just to conclude that we had a positive predictive value and a specificity of 80%, making it a good ruling test, but our negative predictive value was only 57% because we were only using a 5-gene very simple assay. So that we have to, of course, go beyond that. But what we really showed was you can use these cell scrapes to do this test, and this is a very easily performed test. And even in nodal metastasis of PTC, and in PTC, of course, BRAF mutations came up. And in the indeterminate category, the PPV of 80% made this a good ruling test. Now the Introgen has come up with a 7-gene assay, which also includes these fusions, and that can improve the diagnostic sensitivity. But then you will also have to standardize the extraction of RNA from smears, or you could do it on a directly collected sample. And we are moving forward, and this is the latest that is coming up, detection of BRAF in droplet digital PCR. This will be a real game changer because it is, again, droplet digital is very, very easy to do. And here is another paper which has combined TERT and BRAF mutational profiling using droplet digital PCRs. And that is going to be a revolution. And as I can see into the future, that's going to come into our practice. With this, thank you very much for giving me this opportunity. And I'll go first.
Any quick question or comment? Very quick. Yes, Shipra.
Yeah. Indeterminate nodule.
Yeah, of course. So have you tried these mutations in those models and compared the proven malignancy versus borderline lesion? Right? That's what we take. Exactly. So there were only 21 cases. A lot of variations in in our kind of going to detail, but 24 were the total indeterminate thyroid nodules. That's 4 is 5. I think out of that, I think category 3 were relatively but histopathological confirmations available only in 4 of them. So not every section is not available. So you really need to work on that aspect. In fact, pull data from multiple centers, go back and if you do a retrospective analysis, you don't have directly connected samples. You have to use the appropriate centers and then very illustrative and very
Okay, thank you very much,
Thank you, sir.
Radhika, for your nice presentation. Thank you very much.
Thank you so much, Professor Radhika ma'am, for enlightening us and sharing your deep knowledge on molecular testing.
Last but not the least, part of this session is case presentation. For that, I would like to take this opportunity to invite our chairperson, Professor Pradyuman Singh sir from Department of Pathology, RML, IMS, Lucknow.
Professor Didi Malik ma'am, she is head of Department of GMC Bhopal.
Dr. Rashmi Chaturvedi, she is a pathologist at Cancer Institute, Lucknow.
I request to Professor Chanchal ma'am to kindly present a few interesting cases. She's a professor at KGMU, Lucknow.
नीचे का स्क्रीन दिख ही नहीं
Should I start? Good afternoon, everyone. Today I would be discussing one case. It's a very interesting case on thyroid pathology, and it was diagnostically quite challenging for us also. So this is a case of an 18 years old female. She presented with an anterior neck swelling, which was progressively and painlessly increasing in size for 1 year. It was moving with deglutation during examination, so means it was from thyroid. It was not associated with any compressive symptoms, and there was no significant family history. This girl also had a history of medulloblastoma, which was treated 5 years back with multiple cycles of chemotherapy and radiotherapy. Her investigations, biochemical investigations were largely normal except for a deranged TFT, that is, she had mild to moderately elevated TSH, that is, had hypothyroidism. CT scan was performed, and on CT scan, the thyroid gland was bulky, and the entire thyroid gland, including both the lobe and isthmus, was studded with multiple nodular lesions. Although the capsule was intact, there was no extrathyroidal extension, as well as no lymphadenopathy, neither cervical or superior mediastinal. Unfortunately, we didn't have the FNAC smears of this patient because she underwent FNAC outside, and it was reported as papillary thyroid carcinoma. And the features based on which this diagnosis was given was high cellularity, presence of papilloid fragments with nuclear grooving and occasional inclusions. So with these findings, she came to the Department of Endocrine Surgery, and based on the history and the FNE finding, a total thyroidectomy was planned and with bilateral central lymph node dissections. And the specimen was sent to our department in KGMU. So grossly, the entire thyroid gland, the bilateral lobe as well as isthmus, correlated with the CT findings, that is, there were multiple grayish-white solid nodules which were unencapsulated with ill-defined borders at places. It was involving almost whole of the thyroid parenchyma. Some of the normal thyroid tissue was identified at the periphery. There was no gross extrathyroidal extension, and a parathyroid gland was also identified, which was later reported as a parathyroid adenoma. So just to make this session a little interactive, I would be showing the pictures of the histopathology slides, and I would really love to have your inputs on that. And slowly and steadily, we will proceed toward the diagnosis. So this is a scanner view of this case, or low power view. And as you can see, there is a largely well demarcated growth
with some normal thyroid which is seen at the periphery. This is the tumor part and this is the normal thyroid parenchyma part. The interface is not well defined, but it is largely well defined with some irregularity. And at low power, we can see that it has some sort of cribriform pattern and some microcystic pattern as well. This is a higher power view which shows a predominant cribriform pattern. And we can see that there are multiple nodules which are separated by fibrotic septa or fibrotic stroma with some lymphocytic infiltration focally at places. This is again a higher power view to give a better idea of what the cells were looking like. And this picture is basically for the nuclear features. Now, based on these features, we can see that the nuclei are vesicular and they are having a prominent single centrally placed nucleolus, which is quite often seen in almost all the nuclei. Grooving was prominent and at places some pseudo-inclusion like appearance was also there, maybe like this and something like this. There was no extrathyroidal extension on histopathological evaluation also, and both the lymph nodes, there were two central compartment lymph nodes along with the specimen and both of them were negative. So I would request to please give your opinion about that based on the histomorphological features, what do you think would be the probable diagnosis or the differential diagnosis in this case? Anyone? Yes, ma'am. So the initial thing that came into my mind was cribriform morula variant of PTC. Since the patient was quite poor and was not able to pay for higher investigations, this case was actually initially reported as cribriform morula variant of PTC only. But some time back, I got an invitation to collaborate in an international project where they were studying a specific type of neoplasm, and this case remained at the back of my mind, and therefore I investigated, used some panels afterward when it was initially diagnosed, maybe 1 or 2, 3 years later. So these are the immunohistochemical pictures. Now, this was a surprise that this tumor was thyroglobulin negative. It was negative for TTF1. CK19 was also negative and EMA was also negative. So this was the IHC itself was a shock. Proper controls were there. The normal thyroid was positive for thyroglobulin and TTF1. The Ki67 index was lower, means it was less than 5%. So it has had a low proliferative index. So now again, the same question. What could be the probable diagnosis, or what is the next thing that pops in mind? So further IHC panel was performed, and this was the panel which I went for, thinking about the prominent cribriform pattern and microcystic pattern. And to my surprise, these markers came out to be positive. The tumor was strongly positive for mammoglobin. S100 was also positive, and there was patchy positivity for PAX8. So based on these histomorphological and immunohistochemical findings, everything finally went in correlation with mammary analog secretory carcinoma thyroid, which is a recently recognized entity. It was identified in salivary gland in 2015, but it was only after 2017 that it was documented in thyroid gland. So it is a very rare tumor to be present in thyroid. So fish analysis was also done to confirm it. And I collaborated with Dr. Shipra, and this investigation was performed in AIIMS for this patient, and this is the fish picture. Now, again, this is the second surprise that we received on fish. An ETV6 NTRK3 fusion probe was used. So we were assuming that we would be seeing a lot of yellow signals because we were expecting this fusion to be present in this particular case because mammary analog secretory carcinomas are associated with this translocation and genetic abnormality in almost all the documented cases. So, but in this case, we saw 2 separate green and 2 separate red signals. So there was no fusion of ATV6 and NTRK3. So based on these findings, I did a lot of literature search to justify that how it could be explained. All these things can be put together. Finally, I found some literature which I would be sharing with you. And I consider it to be as a mammary analog secretory carcinoma thyroid without classical ETV6 NTRK3 fusion. When I was undergoing the literature search, many cases are documented. In fact, series are there of 3 cases, 4 cases, where ETV6 gene can have a different fusion partner. Most of the time, it is NTRK3, which is now considered to be a diagnostic genetic abnormality in this tumor. But in series, it was documented that it can pair with NTRK1, NTRK2 commonly. And there are few cases reported, 3-4 cases reported in which the fusion partner has not been identified. And they are being reported as ETV6 gene X fusion cases. So the histomorphological finding, pathology, IHC findings, and the molecular, the fish findings can be explained by putting it under this category. The patient is still in follow-up. She has not developed any recurrence or lymphadenopathy, and she's in a perfectly fine and healthy situation. So a little bit about this rare tumor. It is a rare salivary gland tumor. It was first described in 2015. But was more talked about after 2017 when it came in the WHO Blue Book. In thyroid, less than 10 cases have been documented so far. Usually it involves middle-aged females, usually in an age range of 36 to 74 years. And this tumor should always be suspected whenever there is a presence of microcystic and cribriform pattern, especially when the nuclear features are not entirely that of PTC, means a lot of nuclear clearing is not there and a conspicuous nucleoli with some cytoplasmic vacuolization or vacuolated cytoplasm is seen. The origin of these tumor is debated, and some think that it is a primary thyroid tumor from ectopic salivary gland remnant, which are present either intra or perithyroidally. Some suggest that it could be metastasis from an occult primary salivary gland and breast tumors. In the present case, salivary gland and breast were normal. And some suggest that it may have the same origin as papillary thyroid cancer because some MASCs can coexist with PTC and can share some molecular alterations. So case reports like this are also available. It is important to diagnose this entity and subtype this tumor group because it has an aggressive course and is usually, not always, but usually insensitive to radioiodine. So it won't be of much use of subjecting a female patient, especially in a fertility age group, to expose her to a radioiodine treatment. So it is important to diagnose it. It can, in fact, undergo dissemination and can lead to fertility, and recurrence is also very frequent. The current WHO has included a separate category in thyroid classification as salivary gland type tumors in thyroid. And these are the essential and desirable criteria which are considered at present, that they have a characteristic morphology with mammoglobin S100 positivity and absence of thyroid differentiation and ETV6 translocation. So these were the two main studies which I came across. The first study is by Ito et al., in which they documented two cases in which they were not able to identify the second partner for ETV6 gene fusion. And the other studies is by Skalova et al., both during 2015 and 16. This is a series in which they did molecular analysis of 25 cases, and out of that they found 4 cases that harbored ETV6X and X gene fusion, and there were 2 cases in which they found the supporting partner to be NTRK1 and 2. Now, since we don't have the probe for NTRK1 and 2, so that has not been evaluated, but this is an unusual case, not only in terms of a rare entity, but also in terms of absence of the classical genetic abnormality, which we intended to document. Thank you.
So, very interesting case, Dr. Chanchal.
Thank you, sir.
So, can we have a discussion on this at the moment, or should we take the questions at the end? Dr. Vineet, any comments or questions at the moment?
Very interesting. The lesson learned is that if you have a real baby with a type of tumor in the thyroid, please go for IHC first, and not happy, then go for
Right, truly said.
Yes,
So that
ma'am.
was the
TTF should always be done whenever there is such a situation. And apart from cribriform marula, which is now, in fact, in new WHO is no more considered a variant of PTC also. So it can be another thing that could be thought of. Thank you, sir.
All right, thank you so much.
So another lesson is that you keep on following in your question mark cases. Otherwise, if she wouldn't have had followed this case after so many years, ye sara hota hi nahi. Congratulate. I really congratulate you.
Thank you so much, Dr. Chanchal ma'am, for this interesting case. Now I request Dr. Nidima. She is a senior resident SGPGI and present an interesting case. There are some questions. We will take questions after this case presentation. Good afternoon to all. I'm presenting a interesting case with a strong family history. This is a case of 42-year-old male businessman by occupation, resident of Lucknow. The patient presented with the burning pain in abdomen since 4 to 5 years and paroxysmal raise of blood pressure. And no significant history like fever, nausea, vomiting, or any abdominal stria or facial hair. And outside patient consult and then ultrasound abdomen showed bilateral solid cystic suprarenal mass with the central areas of necrosis. And probably it was adenoma or pheochromocytoma. Spot urine metanephrine were raised. However, spot plasma and metanephrines and normetanephrines were within a normal range. This is a family history of the patient. So our patient, 41-year-old male, was diagnosed as a MEN 2A, and his 2 of the daughter also diagnosed as a MEN 2A. And the patient sibling also had a history of MEN 2A, and his wife was diagnosed as breast carcinoma with a BRCA1 mutation, and his daughter also had a BRCA1 mutation. And the patient's grandfather also had a history of blood cancer. On general examination, patient was conscious, alert, and cooperative, and vitals were within the normal range. And neck examination showed a nodule in the left side of the thyroid. For abdominal examination, showed no significant organomegaly, and neck examination showed a left side thyroid nodule. After that, patient investigated in the SGPGI, and his urine metanephrin and normetanephrine were raised more than 10 times. CT abdomen showed a bilateral, well circumscribed mass. This is the left side mass, measured around 10 by 8 centimeter, and this is the left side suprarenal mass, measured 5 by 5 centimeter. The ultrasound ultrasound of the thyroid showed the bilateral thyroid nodules and thyroid spore. CECT neck showed bilateral neck nodules also. Then we did the FNAC from the bilateral thyroid nodule. This is a FNA smears of the thyroid nodule. The smears are moderately cellular and showed atypical cells. This is a clusters of atypical cells. This is for the high power view. Here we can appreciate these clusters are dispersed and showed the moderately pleomorphic cells, which are plasmacytoid in appearance and showing dispersed chromatin and moderate amount of the cytoplasm. So the FNAC from the thyroid nodule was reported as suspicious for medullary thyroid carcinoma, Bethesda category 5. The total neck scan of the abdomen and neck also showed the nodules. This is the neck nodule measured 1.5 by 1 centimeter with the avid uptakes, and this is the abdominal mass. This is the right. This is the left side mass, and this is the right side mass. Also showed uptake in the lesion, and the biochemical parameters were significantly raised. The calcitonin, serum parathyroid, and PTH and CA also raised significantly. However, serum calcium and vitamin D within the normal limit. Technetium 99 also showed the cold nodules in both lobe of the thyroid, likely medullary thyroid carcinoma. After that genetic testing, patient showed the RET mutation also. And after that, patient operated and we received 2 labeled specimen of the adrenal. This is the low power view. Here we can appreciate the tumor morphology of the adrenal. This is a capsule and the tumor cells. Tumor cells are arranged in the nest. This is high power view. Here we can appreciate the tumor cells are arranged in the nest. We can call this is gel ball pattern. These nests are separated by thin fibrovascular septae. This is a reticulin stain. This also highlights the these gel ball pattern of the tumor cells. This is a further high power view. Here we can appreciate the individual tumor cell morphology. Tumor cells are moderately pleomorphic and occasional bizarre large nucleus also appreciated. This is another area of the tumor. Here we can appreciate occasional mitosis and bizarre cells. So the bilateral adrenal was reported as a pheochromocytoma, and the PAS score in the left side of the adrenal was scored 1. After that, received cervical lymph nodes for the frozen sections, cervical lymph node and level 2 lymph nodes. This is a frozen section of the cervical lymph node, showed the tumor infiltration. And this is the paraffin section of the same frozen section. We can appreciate the loss of architecture of the lymph node. And the high power wheel, here we can appreciate that the lymph node showed the tumor infiltration by these tumor cells. The tumor cells are showing a moderate pleomorphic nucleus with the dispersed chromatin and moderate amount of eosinophilic cytoplasm. Along with the areas of these eosinophilic, congophilic deposits, and which highlighted on the Congo-Redis stain on polarized microscopy. Here we can appreciate this apple green birefringence. So this was reported as metastatic medullary thyroid carcinoma. After that, received the total thyroidectomy, CCLND, SLND, and inferior parathyroid. This section from the thyroid nodule, this is a normal part of the thyroid, and this is a tumor. Here we can appreciate this infiltrating tumor. The tumor cells are arranged in the nest. This is high power view. Here you can appreciate the tumor cell morphology. Tumor cells are showing minimal pleomorphism with the round to oval nucleus and prominent nucleoli with dispersed chromatin and a moderate amount of the cytoplasm. This is the oil immersion view. Here we can appreciate the individual cell morphology and this congophilic deposits. This is another area of the normal part of the thyroid. Here we can appreciate the C cell hyperplasia, the clusters of C cell in the normal part. And this is another area. Here we can appreciate these C cell hyperplasia with the transform into the tumor. And this is section from the CCLND lymph node showing the effaced architecture and tumor infiltration in the lymph node. This is this is section from another lymph node showing multiple granulomas also. Section from the parathyroid showing the compressed part of normal parathyroid, and this this is a hyperplasia of the parathyroid. This is high power view of the same. So finally, this was reported as medullary thyroid carcinoma with C cell hyperplasia, CCLND lymph node showing metastasis, SLND lymph nodes also showing metastasis of the medullary thyroid carcinoma, and right SLND lymph node showing medullary thyroid carcinoma along with granuloma. And inferior parathyroid was reported as parathyroid adenoma. So now coming on the discussion part of the this case, this was a MEN 2A, the case of MEN 2A. And the patient has a strong family history of MEN 2A, and patient is also has a carcinoma medullary thyroid, pheochromocytoma, and parathyroid adenoma. Any questions? I have time to discuss this, or any? Should I discuss?
So very interesting cases, and men cases always have the spectrum of lesions that it can present can pose an enigma, and also challenging range of findings that can come across. Any comments or questions to the presenter?
Ma'am, yes, ma'am. PPT. This is our patient, and this is sibling of the patient. Patient sibling also have the same tumors, bilateral pheochromocytoma and medullary thyroid carcinoma. And her both of the daughters diagnosed as a MEN2A, but no operative procedure was done. And patients, this sibling and his wife was diagnosed as a BRCA1 mutation with breast carcinoma. Yes, sir. Yes, yes. Regular follow. Thank you.
Secondary carcinoma, then fetal hyperplasia doesn't mean anything.
Ma'am, because T-cell hyperplasia generally associated with the syndromic medullary thyroid carcinoma.
But the cursor lesion is fetal hyperplasia.
Yes.
If there is prophylactic thyroid, then it is important. Children, for example, that may show you only fetal hyperplasia and not that ability for.
So there is no mention of the diagnosis of the two daughters. What was their diagnosis? No operative procedures. Yeah. Thank you so much. Who is the next presenter?
Ma'am, that's all. That's all.
Yeah, please.
Yes, ma'am. Ma'am, we have only two presenters. Thank you so much for both the presentation, and thank you so much to our honorable chairperson for this insightful session. We have two questions for Dr. Chanchal Ram. It's in the chat box. What was the beta catenin stain in this case? Is 100 is positive. It's not like memory analog secretory carcinoma. It's in the chat box.
Yeah. Okay. Beta catenin was not done in this case, and S100 was positive, but it was positive in the tumor cell, although it was not that full-fledged positivity in the entire tumor cells. But what positivity of S100 was there was definitely in the tumor cells. Beta catenin was not done. But the other findings, especially mammoglobin, positivity and negativity of TTF1 and thyroglobulin. These are the three main markers that would be able to differentiate it from others, differential diagnosis.
Okay, ma'am. Thank you, ma'am.
Is there any more case presentation?
No, ma'am. We are.
So we'll thank you for the very beautiful two cases which has been presented here. And I would specially say for the second one, they have presented with a very beautiful radiological pictures. That was quite nice.
And thank you everyone for sharing your knowledge with us, and it will be a great pleasure to listen you in the future in our future events. Now it's time for a lunch break. We would like to request all our respected delegates. Lunch is waiting for you outside. After that, Dr. Rishabh and Dr. Shikha will resume the session at 2 p.m.